FRCS teaching webinar. The topic tonight is about cervical trauma. This is presented by Athar Siddiqui, who is a spinal senior fellow from London, and he is one of the senior mentors on this group. I'm Firas Arnaout. I'll be moderating the session for you. And we have Kashif Memon, also one of the senior mentors here to support us. If anyone has any question or you'd like to take part in the viva practice session that's after the presentation, please raise your hand symbol or send a message through the chat option. Yeah. And just a reminder that everyone who attends is eligible for a CPD certificate. Just contact me through the Telegram group or Facebook if you want to request one. And as you all know, the presentation will be recorded and edited and then afterwards published on the YouTube channel Orthopedic Fellowship Preparation course for you to revise. Over to you, Atar, now, please.
Okay, guys, good evening. So today's topic would be cervical spine trauma or cervical spine curriculum. The curriculum is exhaustive, so I wouldn't be able to cover everything. However, I will try and cover all the questions that has been previously asked. It's only subtopic of a spine topic, and it's unlikely that you get asked it very often. However, one spine question or two spine questions do pop up in the exam. And whether it comes in your adult path, whether it comes in your trauma viva, or whether it comes in your short case, long case. Long case, it's unlikely. The only long case that comes that involves cervical spine is actually a rheumatoid or spinal cord pathology. However, today's topic is cervical spine trauma, so we'll start. So basically, as a part of cervical spine trauma, all trauma patients have got cervical spine trauma unless proven otherwise. Cervical spine trauma has to be cleared both radiologically and physically. Physical examination involves obviously percussion, look, feel, move, and spatial test as of any other orthopedic examination. In a trauma setting, in an ATLS setting where there is airway, breathing, circulation, and circulation comes or breathing comes with cervical spine immobilization and inline traction. So basically at that stage, you just press around the cervical spine, make sure you cannot find any gaps, any point of tenderness or any steps. Other clinical evaluation involves evaluation of any neurology that can present in terms of radiculopathy, monolateral, bilateral, or signs of complete cord damage. In terms of x-rays, cervical spine lateral x-rays used to be part of the curriculum. Initially, ATLS, it used to be part of ATLS as well. In some hospitals, it gets done. And it's a very favorite exam question where they ask you, where they show you a lateral cervical spine x-rays. They ask few things there are few pet questions about this lateral cervical spine x-rays. One, whether the spine x-ray is adequate or inadequate, and you have to see the superior border of the T1 for you to say that it's adequate x-rays. Also, you need to comment on the 4 lines, which has been mentioned there: the anterior vertebral line, the posterior vertebral line, spinolaminal line, and posterior spinous process line. All these lines are self-explanatory if you know the vertebral anatomy, and any disruptions in those particular lines will give you an idea as to what is going on. So clearance is defined as confirmation of the absence of the cervical spine injury. We have talked about a physical examination and radiographs. Previous slide only, Kashibhai. We have talked about physical examinations and radiographs, and we just wanted to make sure you know as to why it is important. One, high rate of missed cervical spine injuries is there. due to inadequate imaging of affected level, loss of consciousness, and multi-system trauma, means there are distraction injuries. Also, when one spinal injury is present, there is reported, as you all know, that there is a 10 to 15% chance of patient having injury in other part of the spinal column as well. Now, a removal of cervical collar without radiographic studies is another paramount of your ATLS, and as you attend the trauma call, you need to take that. And there are strict indications for that. The indications are: patient should be awake, alert, and not intoxicated, has no neck pain, tenderness, or neurological deficit, and has no other distracting injuries that is causing that. Okay, now we come to the core topics. Now the first topic is the occipital condyle fractures. The occipital condyle fracture, also called as C0 fracture, is fracture of craniocervical junction. It is 1, 2, 3 types, as you can see on in this video, or on the slides. Sorry, not in the video, on the slides. Type 1 is compression, type 2 is direct blow, and type 3 is rotational. The reason why this we need to know about this topic, the occipital condyle fracture, is because of its high mortality rate. If you see an occipital condyle fracture, there's more than 10% chance that, or roughly around 11% chance that you can die because of where it is. Obviously, all the ligamentous instability should be assessed at that stage, and the radiograph of choice or imaging of choice would be CT scan, MRI scan, and further evaluation as appropriate. Now, most of these injuries are treated with the rigid collar or semi-rigid collar like Miami J collars. However, very unstable injuries will be treated with, which is type 3 type of injuries, where you see the displaced fragment behind the peg. These sort of injuries you can treat with C0 to C3 posterior arthrodesis. The only thing what you need to know is there are 3 types. It's compression, direct blow, or rotational. Rotational type 3 is the one which is the most unstable one, and if it comes to the treatment, it requires some sort of fixation, mainly posterior. The reason why we are discussing it, because of its high mortality if we fracture it. Okay, now we come on to the other slide, please, Kashif bhai. If you come on to the other slide. I think I have other, so yes. So orthopedic manifestations that can be, is because, why is it important? Go back to the other slide, sorry. Stick manifestations that can come here, The other orthopedic manifestation that can be here will be either cervical spinal cord injury or polytrauma. Medical manifestations can come as well, because it's a direct blow to the head in form of intracranial bleed, brain stem, vascular lesions, or elevated intracranial pressure. Okay, we go on to the instability, or the next slide. So the next slide would be for atlantoaxial instability. This is again a part of FRCS curriculum, and it can come in any question. For all practical purposes, you will see atlantoaxial instability in rheumatoid patient. It can be a part of your long case, where once you are done everything and you've come up to the level where you're discussing instability and why is it important in rheumatoid patients to have lateral spine x-rays as a part of pre-operative planning, is atlanto ADI and space available for cord, so that you can plan ahead. Your anesthetist have this information, your anesthetist have this information on hand, and they can talk about either fiber optic, awake, intubation, or any intubation that doesn't require hyperextension or hyperflexion of the is Down syndrome, again in young patient, or in pediatric causes where you can have juvenile rheumatoid arthritis or rotatory atlantoaxial subluxation. So remember these apical LR ligament complex. They are called transverse ligament, apical ligament, and LR ligament. Remember that transverse ligament are the most important stabilizer, and we would know about it in the lateral mass fracture later on in the presentation. Apical ligament is a midline structure, and LR ligaments are paired sagittal ligaments, and they are responsible for instability, anterior-posterior instability. Thank you. If odontoid fracture, adult or pediatric, remember that odontoid have got multiple ossification centers, and these are the ossification centers that are there. You guys may have this MCQ or EMQ question in your in your part 1. However, these questions can come in your part 2 as well. So remember the ossification centers. Remember about the os odontoid, which you should know as well, because you can get easily caught by mistaking os odontoid as a type 2 odontoid fracture. Also remember important stuff about these fractures. Just remember important stuff. The first important structure is it occurs in bimodal fashion. Yes, it occurs in bimodal fashion. Like it can happen in elderly, or it can happen in young patients. Why can it happen in young patients? Because their necks are very mobile, and then it hinges on the odontoid. The other important, as I said to you about os odontoid, and just remember it, because it can look like a type 2 odontoid fracture on x-rays, on a lateral x-rays. So someone just asked how to differentiate between os odontoid and type 2. It's very hard. CT scan can tell you. Type 1 is an oblique avulsion fracture of the tip of odontoid due to avulsion of alar ligament. Type 2 is a fracture through the waist. This is stuff, and always remember that type 2 is the one where you can think about high non-union rate, and it is due to disruption of the blood supply. Type 3 fracture extend into the cancellous body, and it involves variable portion of the C1, C2 joint. It's actually a good thing, because if it involves a more joint, if it involves more surface, means it is going to heal quicker, even in a rigid collar. Of this odontoid fracture, like everything else, 1, 2, 3. Non-operative treatment should be for type 1 and type 3, and in patients who are obviously very old and unlikely to sustain or anesthetically fit for such an extensive surgery. The second treatment is either halo bracing or rigid collar, and the third treatment is surgery. Always remember, you're not going into the nitty-gritty of what surgery you would like to perform. Always start small and then build up on it. The smallest thing to say here is surgical fixation. Then they will say what surgery. Now you're getting into the gold marks. So what surgery means either anterior or posterior stabilization. What do you mean by anterior stabilization? Anterior stabilization is through the same anterior approach, ACDF approach, where you put one screw. However, fracture pattern is quite important in this type of surgery as to which side the fracture is going. And so if it's anterior superior and posterior inferior, the screw can go in from the front without displacing the fracture. However, if it's a reverse fracture where anterior is inferior and posterior is superior, you try to put the screw in from the front, the fracture will displace more. So these things, these are small points which they ask, and that's why this odontoid fracture treatment is important. The other thing to say here is the posterior fixation. What is the problem with posterior fixation? This is common FRCS question. So the posterior fixation is because you are operating so close to vertebral artery, and you have to have preoperative CT angiogram or CT for your planning of your posterior instrumentation. So remember these 2 points, and then you will be okay. So we move on to traumatic, next slide, which is traumatic spondylolisthesis of axis. Because of where it is, and because of what catastrophic injury it can cause. It can cause injury to your spinal cord, it can cause injury to your medulla, and it can be really, really unstable, because both sides of pars intercalaris is fractured, and if it's flexion type, it has torn your PLL, which is a PLL, posterior longitudinal ligament, which is again a very important stabilizer when it comes to cervical spine and in stability of the cervical spine. Why do you why you should not miss it? Because this has got 30% concomitant cervical spine fracture injuries as well associated, and you need to screen the whole of the spine, or at least the cervical spine, if you see similar sort of displacement. Treatment wise, again with cervical spine, if you don't know everything, say non-operative rigid collar, closed reduction, halo immobilization, or surgical stabilization. If you say these 3 words, you're going to pass the exam. Everyone knows, you know, the lines which we discussed, the 4 lines which we discuss here. You should talk about how much of the subluxation of C4 over C5, and hence do not commit yourself to unilateral or bilateral. Just say it is most likely to be unilateral, taking the 25% subluxation on the X-ray into consideration. Yes, the other clinical features you will find with unilateral subluxation is unilateral subluxation, as it's on one side, it is associated with monoradiculopathy, means one-sided, whatever side you have dislocation, that sided arm pain. Bilateral will associate it with significant spinal cord injury, either spinal shock or bilateral distribution of signs of cord compression. Most frequently involves our superior facet, whether it's bilateral or unilateral. And the reason why a superior facet is involved in facet fracture, because of its anatomical composition, or because how it is anatomy wise. Now you can give the descriptions on the x-rays, and for exam purposes, because remember, exam happens, it happens in the most ideal hospital in the world where you can get everything. So needless to, for as far as imaging is concerned, if you say something wrong in imaging, it's not going to be a negative mark. So just make sure you say, if it's if you see facet joint, you get MRI and you get CT scan. However, there are people say in curriculum there are specific indications for MRI scan, but in your real life, if you say a facet joint dislocation, you are definitely going to do MRI scan. So say the same in exam. Most likely you see it in C5-6 or C6-7. Spinal cord, we have discussed that as well. Kashba, if we move, have a picture in your mind, and you need to have this treatment algorithm for facet dislocations. If the patient is alert, answer is no, get an MRI scan. Answer is yes, you assess neurovascular deficit. Is there a neurovascular deficit? A pain is not a neurovascular deficit in a single nerve root distribution. If the answer is no, you're getting an MRI scan. If the answer is yes, you are taking patients straight into the theaters for emergent close reduction. Again, if at all someone is going to ask you anything about spinal reduction, it's going to be a facet joint dislocation reduction, because it has been asked repeatedly in the past, and there are few controversies here. When to get an MRI scan, whether to reduce open or closed, and what are the indications of anterior first, posterior second, posterior first, anterior second stabilization. So have a clear picture in your mind as to how you are going to portray yourself in the exam and what are you going to say. So if I were you, if I'm going for the exam, if I see facet dislocation with monoradiculopathy or bilateral involvement, I will always say I'm going to get a CT scan and I'm going to get an MRI scan. And depending on the MRI findings, I will take the patient, I will discuss it with the National Spinal Injury Unit. However, if I'm the Regional Spinal Injury Unit, the principle for emergent close reduction would be adequate anesthesia, sedation, supervision of the respiratory function in theaters, and serial cross-table lateral x-rays. Remember also, when you are reducing it, say some sort of reduction tool, whatever you have in your hospital. We use garden well thongs. They are readily available. Supraorbital 2 pins on one side, supraorbital 1 pin on one side. When you are putting the pins on, ask the patient to close the eyes so that he doesn't have any problems. And then gradually increase axial traction on the weight. There is a strict protocol about the weight as well as to how much weight you can use per facet joint dislocation, but it has to do with body weight. So no one can remember it. I'm not going to tell it. You just say, it has to do with body weight. I will be guided by the spinal surgeons or the regional trauma unit, whatever they say. If you find an anterior disc on an MRI scan, you cannot do a close reduction. So it has to be, patient has to be blue lighted to the regional spinal injury unit, have an anterior cervical discectomy, decompression, and then subsequent posterior reduction and stabilization.
Repeat that again, because that was very important what you said, the sort of absolute indication for patient transfer to a spinal unit. Yeah.
So the absolute indication for patient transfer to spinal unit, if you see an MRI, if you see a disc pressing the cord on an MRI scan, means you cannot do ACDF in your primary hospital, irrespective of whatever neurology patient have. Because what is the first Hippocratic oath that GMC asks us to take? Do no harm to the patient. By doing a procedure which you are not trained on, you will do more damage than any good to the patient. So to be a safe doctor, however, if you don't have the facility, don't get tricked into this thing, oh, the other National Spinal Injury Unit is 2 hours away, would you not keep the patient, maybe do the anterior approach, do the discectomy? No is the answer. If there is a disc, patient need to be transferred across and have the operation, because it will be an anterior. Yes, Atif. Atif is asking whether we get an MRI scan in all cases. The answer to that, if I were you, I will say yes. Because if you say no, then you are stepping into their trap. And then they're going to start asking you about the indication of when to get an MRI scan, when not to get an MRI scan. You say, I'm aware of an algorithm, which is already discussed. So we move on to the next slide, but always, go through this slide again, taking the close reduction requirements and technique into consideration. Make sure that the patient is awake. Make sure there is adequate anesthesia. Make sure you have an anesthetic colleague in there, so who's going to assess you in case you give too much sedation. A component of cervical flexion also facilitates reduction. And why does it facilitate reduction? so that you can lodge the superior facet behind the inferior facet. And that is taking into the cervical spine anatomy into consideration, and abort if there is neurology appears, and get immediate MRI scan, irrespective of whether you got an MRI scan before or not, so that you are looking at any changes within the scan. Fracture separation. Now, why is it important? This lateral mass fractures, why is it important? It is important because it affects two motion segment, and as the superior facet and the inferior facet on either side are fractures. Garden-Well thong is the name of the tongs. Are important because it affects two level. Location mostly at around C6, followed by C5, 7, 4, and T1. Always remember that there are associated conditions with anterior translation of fractured vertebra, superior adjacent vertebra fracture, or inferior adjacent vertebra fracture. They are very unstable, and you need to know as to what are the parameters of instability. In the next slide, you will see, and that is as much as you know in this particular. The instability parameters are if you have more than 3.5 millimeter displacement on either side, or a combine of 7 millimeter displacement, if you have kyphosis of 10 degrees, or if you have rotation compared to adjacent vertebra of 10 degrees. So it's a three-dimensional thing. Again, like everything else, get a CT and an MRI scan. Don't stay confused. Why to get a CT, why not to get a CT? Because over here you will see about 50 to 60% there is disruption of the anterior and both posterior longitudinal ligament, which is very important stabilizer as far as spine is concerned. Treatment, as of everything else, as I said to you in the beginning of the talk as well, if you say non-operative treatment, semi-rigid collar, and cervical stabilization, that is as much you're going to say. Once you say that, it is what I think it should suffice. The only details in treatment what you should know, it's about the odontoid pec fracture. As far as the fracture anatomy is concerned, when you're planning anterior fixation, and when you're planning posterior fixation, the vertebral artery, and the other treatment is the facet joint dislocation, where you're either taking patient to theater for close reduction, or if you're taking patient to, or if the National Spinal Injury Unit or local spinal injury unit is taking patient to theater for anterior stabilization, you need to know about the disc. And maybe if you're doing very good, they will ask about the anterior approach, which is the Smith-Peterson approach to the cervical spine. So that approach you need to know. If you don't know the approach, don't go to the exam either. So these are must-know things. And
the adequacy, it shows the examiner you are a safe surgeon. You're not going to miss junctional problems. So when you practice yourselves, guys, please always say that sentence, checking the adequacy of the x-rays. And again, with the facet joint dislocations, and maybe Athar could clarify this or confirm or not. There is a lot of issue. Is it unifacet, bifacet, dislocation? We keep, arguing, discussing this issue. But as far as the exam is concerned, we don't need to worry too much. I think facet dislocation is facet dislocation. Don't commit yourself to uni or bifacetal dislocations. You still need to manage it more or less in a similar manner. Is that correct, Atar? Yeah.
Exactly.
Yeah. So that, 25%, is it 30%? Is it?
Yes. It matters. It doesn't matter at all. Just everything. So someone asked 3 things to say. Please repeat the 3 things. So I will add on to it. There are 2 things and 3 things. 2 things is how do you investigate it, You investigated CT, MRI. CT will delineate bony anatomy. MRI will give you ligamentous instability and all the rest of it, any cord issues, any disc issues, any edema around the cord. CT, as I said, will show you the bony anatomy, plus if it's CT with angiogram, it will show you about the vertebral artery anatomy as well, which is important in terms of odontoid. The other thing someone asked about the three things are observation alone to see whether the patient works with soft collar. The second thing is semi-rigid collar or semi-rigid collar or hard collar or halo bracing following reduction. And the third thing is surgical stabilization. So in spine or in cervical spine, for that matter, if you stay as vague as possible, start small, and then you can build on it. Make them ask questions. So if you say surgical stabilization, then they say, okay, what surgical stabilization options available? So you say there are two surgical, in case of odontoid fracture, there are two surgical stabilization options available depending on the fracture anatomy, which is anterior osteosynthesis or posterior osteosynthesis. Then they'll say what are the advantages and disadvantages of each. Anterior osteosynthesis is through a very well recognized anterior approach, and if the anatomy allows, where you can put screw from front to back without displacing the fracture, it is the favorable way of treating it because there are less morbidity associated with it. However, if the fracture is transverse or if it's anterior inferior and posterior superior, and if you put screws from the front, it will displace the fracture, then you go from the back. However, a detailed anatomy of vertebral artery placement should know, and you should mark your screw placement beforehand so that you know you're not going very close to the screw, very close to the vertebral artery. I have seen it done 5 times. One of the time, someone hit the vertebral artery, and it was a.
Thank you, Atar, for explaining.
Thank you.
And I think just to clarify again, facet joint dislocations, we're getting MRI scan.
Yes.
This is UK standard exam, and I don't think we should put any controversies here. Facet dislocation, unless there is other life-threatening injuries, we're getting MRI scan, please. Okay, so I know Miller and other books can confuse matters a little bit with this issue, but for exam, FRCS, please, my advice to you is request an MRI. Okay, so any further comment, Kashif, to add?
No, I think Athar has covered very well. And as you correctly mentioned, MRI, because I was asked this question as well in my exams. And I mentioned MRI, and there was no controversy after that.
Yes, if you don't say MRI, you are stepping into
difficult conversation. You're getting difficult conversation. Then you have to justify where to do MRI, where not to do MRI, and all this stuff. So I think don't go into that controversy. Just say MRI and then get out of that.
And as Athar said, also one other hot topic in the exam with regards to the cervical spine is the anterior approach. Yes. Please read it carefully. And as Athar said, I agree with him. If you don't know it, don't go for the exam. This is the approach in the spine they ask about.
If you're going for the left side approach, only have to do spine for more.